Hello, everyone, and thank you for joining today's COVID-19 vaccine webinar for rural communities. During this webinar, our presenters will review information on healthcare workforce mandates, healthcare coverage related to the COVID-19 vaccine, and provide information on federal COVID-19 resources. At the end of the webinar, we will have a question and answer section. We will take questions from the questions chat box, and we'll address as many questions as time allows. Please note that the slides from today's presentation will be posted on the CMS OMH website in the coming days. Next slide, please. During today's webinar, you will hear from the following speakers: Dr. LaShawn McKeever, Director of the CMS Office of Minority Health; Darcy Graves, Co-Chair of the CMS Rural Health Council and Health Insurance Specialist at CMS; Dr. Peter Marks, Director of the FDA Center for Biologics Evaluation and Research; Shannon Chambers, Director of Provider Solutions at South Carolina Office of Rural Health; Dr. Diane Hall, Senior Scientist for Policy and Strategy Lead at CDC Rural Health; and Dr. Francis Feltner, Director of the University of Kentucky Center of Excellence in Rural Health. Next slide, please. On this slide, we've included an agenda for today's webinar. We will begin with an overview of CMS COVID-19 policies. Following this overview, you will hear from our guest speakers. We will then review various COVID-19 vaccine resources from CMS OMH and other HHS agencies. I will now turn it over to Dr. LaShawn McKeever, Director of the CMS Office of Minority Health. Dr. McKeever, you may begin.
Thank you, Dante. Hello, everyone, and thank you so much for joining us today. My name is Dr. LaShawn McKeever, and I'm the Director of the Centers for Medicare and Medicaid Services Office of Minority Health. Before I begin my presentation, I wanted to take a few moments to acknowledge the National Rural Health Day observance that is coming up in a few days on November 18th. This health observance is one that our office recognizes every year to highlight the unique needs of rural communities. And we also conduct activities like this webinar today to ensure we are meeting community needs and advancing the health of those living in rural areas. So in the next few moments, I will walk you through a few COVID-19 updates, including recent updates to vaccine eligibility, payment policies related to the administration of the COVID-19 vaccine, and a brief update on recent healthcare workforce mandates. Next slide, please. I'll begin by discussing the vaccines that are currently available in the US and their eligibility requirements. As many of you know, currently there are two multi-dose vaccines available: Pfizer, BioNTech, and Moderna. The third vaccine that is available, Johnson & Johnson, only requires a single dose. The Pfizer BioNTech is the only vaccine that has been fully approved by the FDA for all individuals 16 and older. The vaccine has been granted emergency use authorization for individuals who are 12 through 15 years old, and most recently was approved for 5 through 11-year-olds. Moderna and Johnson & Johnson have both been granted emergency use authorization for those 18 and older. COVID-19 booster shots are now available for certain groups that have already been vaccinated. So if you received a Pfizer or Moderna vaccine, you're eligible to receive a COVID-19 booster if you're 65 and older, or if you're 18 and over, and live in a long-term care setting, have underlying medical conditions, or live in a high-risk setting. If eligible, boosters can be given 6 months after your second dose of your initial vaccine series. All individuals 18 and over that received a Johnson & Johnson vaccine are eligible for a booster 2 months after they received the initial dose. Next slide. I want to take a few moments to talk about payment policies for administering the COVID-19 vaccine at a patient's home. Beginning this past June, so June 8th of 2021, Medicare's additional payment amount for administering the COVID-19 vaccine in the home for certain Medicare patients was set at $35 per dose. This payment also applies to additional doses of COVID-19 vaccine that are administered in the home to certain Medicare patients on or after August 12th, 2021, as well as booster doses that are administered in the home to certain Medicare patients on or after September 22nd, 2021 for the Pfizer vaccine and October 20th, 2021 for the Moderna and Johnson & Johnson vaccines. Medicare will pay the $35 amount in addition to the standard administration amount, which is approximately $40 per COVID-19 vaccine dose, for a total payment of approximately $75 for a vaccine dose administered in a patient's home. The additional amount and administration rate can also be adjusted based on where the vaccine is administered, which we will discuss in more detail in the next few slides. Next slide. Providers can get additional payment for administering the COVID-19 vaccine in a Medicare beneficiary's home when the patient has difficulty leaving the home to get the vaccine due to an illness or injury that restricts their ability to leave their home without a supportive device or help from a paid or unpaid caregiver, a condition that makes them more susceptible to contracting a pandemic disease like COVID-19, and being generally unable to leave the home, or when the patient is hard to reach because they have a disability or face clinical, socioeconomic, or geographical barriers to getting a COVID-19 vaccine in settings other than their home. Please note that unlike the requirements under the Medicare home health benefit, you or another allowed practitioner don't need to certify that the Medicare patient is homebound, but you must document in the patient's medical record their clinical status or the barriers they face to getting the vaccine outside of the home. Next slide. The following locations are among those that qualify as a Medicare patient's home for additional in-home payment. So a private residence, a temporary lodging, and that includes hotels, motels, and campgrounds. An apartment in an apartment complex or a unit in an assisted living facility, group home or non-Medicaid nursing facility, a Medicare patient's home that's made provider-based to a hospital during the COVID-19 public health emergency, communal spaces of a multi-unit or communal living arrangement, and assisted living facilities participating in the CDC's Pharmacy Partnership for Long-Term Care program when residents are vaccinated through this program. The following locations do not qualify, and that would be communal spaces of a multi-unit living or communal arrangement, hospitals, except when the Medicare patient's home has been made provider-based to a hospital during the COVID-19 public health emergency, Medicare skilled nursing facilities, and Medicaid nursing facilities, regardless of whether they're the patient's permanent residence. Next slide. Regarding rural health clinics and federally qualified health clinics, Medicare pays for administering COVID-19 vaccines at 100% of reasonable cost through the cost report. These clinics should also use the cost report to bill for administering COVID-19 vaccines to patients enrolled in a Medicare Advantage plan. COVID-19 vaccines and their administration will be paid the same way influenza and pneumococcal vaccines and their administration are paid. And you can find more information on the website that is listed on this slide. Next slide. On September 9th, the Biden administration announced that emergency regulations requiring vaccinations for nursing home workers will be expanded to include hospitals, dialysis facilities, ambulatory surgical settings, and home health agencies, among others, as a condition for participating in the Medicare and Medicaid program. More recently, on November 5th, the CMS Omnibus COVID-19 Healthcare Staff Vaccination Interim Rule went into effect. Under the interim final rule, all facilities covered by this regulation must establish a policy ensuring all eligible staff have received the first dose of a 2-dose COVID-19 vaccine or a 1-dose COVID-19 vaccine prior to providing any care, treatment, or services by December 6, 2021. All eligible staff must have received the necessary shots to be fully vaccinated, either 2 doses of Pfizer or Moderna or 1 dose of Johnson & Johnson by January 4th, 2022. In alignment with federal guidelines, facilities must also develop a process for permitting exemptions based on recognized medical conditions or religious beliefs, observances, or practices. CMS will work with state survey agencies to ensure that facilities are compliant with the interim final rule. And during on-site surveys, surveyors will review the facility's COVID-19 vaccination policies and procedures, the number of resident and staff COVID-19 cases over the last 4 weeks, and a list of all staff and their vaccination status. This, along with interviews and observations, will be used to determine compliance. And if cited as non-compliant, providers or suppliers will have an opportunity to return to compliance before additional action occurs. Stakeholders will have until January 4th to submit a formal comment on this regulation. However, the emergency regulations requirements will go into effect immediately and before any additional response is provided. So CMS will consider and respond to comments after that comment period has closed. In closing, I hope this information was helpful as you're thinking through your response to the COVID-19 pandemic. And I hope that if our office can be of any help, that you will please reach out to us, and we would gladly connect you to others within CMS to help support you in implementing the things that I discussed today. That concludes my portion of the presentation, and I am very pleased to introduce our next speaker, Dr. Peter Marks. Dr. Marks is the director of the U.S. Food and Drug Administration Center for Biologics Evaluation and Research. So I will now pass it on to Dr. Marks. Thank you.
Thank you so much. I will take you through some of the work that was done to facilitate the development of COVID-19 vaccines relatively rapidly. And if I have the next slide, please. One of the things that people ask about for these COVID-19 vaccines is how were they developed so quickly? And the way they were developed relatively rapidly without cutting corners is by condensing the development process so that normally instead of phased development, phase 1, then phase 2, then phase 3, and then scale up manufacturing, the various phases were condensed into single trials or sometimes into 2 trials. And the scale up of manufacturing happened at the same time that the clinical trials were happening. And if I have the next slide, that's illustrated here, where you can see that the next slide shows here that you have the same things going on, except they're stacked up going on next to one another. And that allowed the vaccines to be studied in or relatively quickly and yet rigorously. If I have the next slide, please. The whole thing about doing this quickly meant that the effectiveness of the vaccines was able to be studied in the same manner as it usually is. The one piece that had to be studied a little more quickly is the safety of the vaccines. Normally, we like to wait 6 to 12 months before vaccines come to licensure. But most of the adverse events for vaccines occur within the first 2 months, actually the first 6 weeks after vaccination. And so we put into place a very rigorous overlapping safety monitoring system by the Centers for Disease Control and Prevention and by FDA, whereby we have both passive safety reporting from doctors, patients, and others, as well as an active safety monitoring system where we are able to look using large databases at either claims or electronic health record data to look at millions of records to see if there are any adverse events of interest that are more frequent with vaccination. If I have the next slide. The candidates that we've been looking at here, and I'll talk about the currently authorized or approved candidates, which are the Pfizer-BioNTech 2-dose vaccine given 3 weeks apart, the Moderna 2-dose vaccine given 4 weeks apart. Those are both mRNA vaccines, and the non-replicating viral vector vaccine, a human adenovirus 26 vaccine from Janssen. I just mentioned that there are also protein subunit vaccines in development, and those should be coming along in the not too distant future through the process. At the next slide, all of these vaccines were studied in large trials. The Pfizer vaccine has actually now received approval and not just authorization. In August, on August 23rd, the vaccine was approved based on the fact that at that point, the trial had matured sufficiently, and we had data on 44,000 participants, which is the same size as the licensure trials that are done for standard vaccines. Fair number of cases, 900 cases of COVID-19, which the case split showed that the vaccine was 91% effective. And we had 6-month follow-up on about 12,000 participants. So that allowed us to have the comfort to license the Pfizer vaccine. The Moderna and the Janssen vaccines are both authorized under emergency use authorization provisions. If I can have the next slide. The emergency use authorization provisions, before I go further, are basically, in this case that we're using, are allowing us to make sure that the emergency use authorized vaccines meet the same high standards for effectiveness and for safety, but it simply means we don't have the same duration of safety follow-up, and there are a few other minor differences. But to a first approximation, we're confident in the safety and effectiveness of all of these vaccines. I want to tell you about some recent information that's come out on the Pfizer vaccine related to the younger population, that is adolescents and younger children. For the Pfizer vaccine, they studied the adult dose of 30 micrograms in adolescents ages 12 to 15 in a trial of 2,260 individuals. The demographics were a reasonable cross-section of the population, similar to their adult trials. If the next slide, please. The Pfizer vaccine was also studied at a third of the adult dose, that's 10 micrograms instead of 30, in 5 to 11-year-olds, a trial of about 2,200 individuals, randomized in this case 2-to-1 instead of 1-to-1. Again, a cross-section of individuals. So the next slide. And in both cases, there was really nice efficacy shown. So for the adolescents, there were good immune responses, and in fact, excellent immune responses with the geometric mean titers 1.75, so 1 3/4 higher in the 12 to 15-year-olds than in the 16 to 25-year-old comparators. In other words, excellent immune response in the adolescents. And if I have the next slide, the 5 to 11-year-olds also showed an excellent immune response with the 10 microgram dose. There, the GMT, the geometric mean titers, are essentially equal, which means that the conversion was done well with equivalent immune responses in the 5 to 11-year-olds as the 16 to 25-year-olds. More importantly, on the next slide, you'll see that in the adolescents, there was excellent clinical efficacy with no cases of COVID-19 in those receiving the vaccine versus 16 in the placebo. And on the next slide, you'll see that in the younger individuals, the 5 to 11-year-olds, there were 3 cases in the vaccinated versus 16 in the placebo. And if you recall, I said there was a 2-to-1 randomization, so it's more like 3 to 32, and the efficacy was 91%. Important here to realize that that this particular study of pediatric efficacy was done at a point when there was a lot of Delta variant around. So this is actually showing that even in the setting of Delta variant, this vaccine has a very good effectiveness. If the next slide, please. Importantly, with all of these, obviously, is safety. And the adolescent safety profile and the adult safety profiles are very similar. In adolescents, there's local pain where the injection is given, as well as fatigue and flu-like symptoms, particularly after the second doses, very similar in adolescents and adults. And I have the next slide. A pleasant surprise is that with the 10 microgram dose, the third of a dose of the adult dose in the 5 to 11-year-olds, although injection site pain was similar, the amount of fatigue, headache, muscle pain was reduced. And I think that probably is a real finding and not just underreporting, because the placebo symptoms were reported in a similar number to the older individuals. Have the next slide, please. There are a couple of other issues. We have authorized third doses for the immunocompromised. And when we say immunocompromised, we mean individuals who are on strong immunosuppressants, such as those who have undergone or a solid organ transplantation or who are being treated with medications similar to those that would be used for solid organ transplantation. This third vaccine dose is given at least 28 days following the first 2 doses of the Pfizer-BioNTech or the Moderna vaccines. I should note that this is not a perfect remedy, because the immunity that these individuals get is generally not to the 95% level, but it is better than after just 2 doses. So we recommend that individuals who get this third dose still take precautions of mask wearing, et cetera. The next slide, please. As is in the newspaper this morning, and will certainly be talked about over the next days, boosters for the general population is a very topical issue. There's evidence from the United States and Israel, as well as other countries now, that with time, immunity from these vaccines wanes, whether that's because we did not get the third dose that really should be part of the primary series, or whether it's some waning that would have happened anyway. It's too early to know. But in any case, we believe that an additional vaccine dose may provide more durable immunity and prevent the complications of COVID-19. In fact, the next slide. We therefore have an authorization now where there is actually mix and match allowed of the vaccines. So for everyone over 65, age 65, they're eligible for a booster vaccination. Anyone who received the Janssen vaccine, who's age 18 and over, can get a booster vaccine, a second dose. And then for individuals ages 18 to 64, anyone who has a medical condition that puts them at risk, or who is at increased occupational or institutional exposure, should get a booster. And my guess is we'll hear more in the not too distant future about whether we expand that further. If I have the next slide. So one final thing to just mention is a lot of people have asked, well, what about the youngest children, individuals under the age of 5? Those clinical trials are ongoing. We expect to see those data early in the new year, 2022. And once we see those, we will move with due swiftness to evaluate those, because we understand that a lot of parents are waiting for this vaccine for the youngest children as well. And I will stop here and turn it over. Thanks very much.
Hello, so my name is Shannon Chambers. I'm the Director of Provider Solutions with the South Carolina Office of Rural Health. So first, we want to talk to you about National Rural Health Day. So as Dr. McIver started this conversation, this really is about the great things that you do in your communities to support your rural patients, your practice, your staff, your communities, everything. It's not just a day, it really is about a movement. One of the really awesome things that's out there right now is that there is a community star, and there is a community star in every single state this year. So we encourage you to go out to NoSour's website and find that information, which will be published widely tomorrow, and tell us about what you're doing. So you'll see the hashtag here, Power of Rural. We look forward to seeing those stories across the country for you to really tell how you're celebrating this day again, not just a day, but a movement. Next slide, please. So we're going to talk a lot about the best practices that you have. So next slide, please. So what are some of the best practices? So of course, for vaccines, we want to ensure that vaccine handouts are available in multiple languages. In a recent study, there are about 1,300 languages across our country. We want to make sure that if we need Spanish or we need French or any of that, that we have those available for our patients. Try to find a physician champion, a strong community leader that can help you to lead the conversation about why vaccines are important. And then, do you have open appointments where anyone can just walk in and get the vaccine, or do I actually have to schedule that vaccine appointment in advance? If I have, hey, we're always open on Fridays from 8 o'clock until 11 o'clock where you can come in and get your vaccine. Do you have those type of things available, or early Saturday mornings? Social media campaigns, while those are great options for getting vaccine information out there, of course, we know that you're also going to probably get some bad comments. That's kind of part of how it is, right? So making sure you have someone that can monitor that information and make sure that you're sending out some of those social media things. We've heard some amazing, as part of the project with NOSOR and our friends at HRSA and the Federal Office of Rural Health Policy, we have heard some amazing hashtags and themed approaches that have been done. Vaccinated and caffeinated, I got my vaccine for my grandmother, or things like that. So share those with us. We would love to have that information. And you'll get my email address at the end of this. I'd love to be able to highlight that and share that with our partners across this initiative. Next slide, please. So let's talk a little bit about the RHC Vaccine Confidence and Hesitancy Grant. The RHC Vaccine Confidence and Hesitancy Grant was awarded across multiple states across the United States. This was for rural health clinics only. Next slide, please. This allowed all of the clinics to actually work on vaccine confidence and hesitancy. Those grant funds were a little bit under $50,000. So NOSOR, the National Organization of State Offices of Rural Health, is the TA provider for this grant. And we can meet directly with those rural health clinics, whether that's to discuss your work plan, a budget review, or really answer any questions that you may have. We have a great relationship with our awesome HRSA team, so Federal Office of Rural Health Policy team, and meet with them every single week about everything regarding our vaccine confidence and other grant initiatives. Your period of performance is July 1st, 2021 through June 30th of 2022. Some people just received their notice of awards in August. So again, that backdates to that July 1st date. There is a dedicated email address where you can reach us directly to get assistance with your work plan, or if you're like, oh, I wish I would have changed this, or I wish I would have done this. Feel free to reach out. So that's rhcvaxconfidenceinfo@nosor.org. And the link provided down below is, of course, the information directly from the website about the Rural Health Clinic Vaccine Confidence Award or Vaccine Confidence Program. One of the most awesome things about this is this was really dedicated for rural health clinics. And so the applications that we received and met all the criteria were approved. One of the first specific rural health clinic programs created, and we're super excited to be a part of it. Next slide, please. So now we're going to talk a little bit about RHC COVID-19 vaccine distribution. So we want to make you aware of a program that is also an alternative to whenever you're getting your state vaccines. Next slide, please. The information here is actually direct CDC distribution. This wonderful opportunity is really for your rural health clinic to receive direct shipment to your clinic. The ordering is pretty simple. Once you get set up and have all your information out there, they have a great team that'll help you walk through it. You can request all 3 vaccines. How important is this going to be if, especially trying to get all the boosters out, as Dr. Marks was saying a minute ago, and things like that? This does not interfere with your state vaccine distribution. So make sure that, so maybe your state says, okay, we can get you 50 Pfizer doses, and you really want 300 Pfizer doses or 400 or whichever. There is a minimum order number that you're going to do a vaccine clinic maybe next weekend in the high school parking lot. So this is another opportunity for you to get those direct shipments right to your clinic. Next slide, please. And then here's our contact information. So you'll see here RHC COVID testing info at NOSOR. So you've probably talked to some of us across the, or we've talked to you across the country as part of the COVID-19 testing, and then, of course, the COVID-19 testing and mitigation funds. My email address is provided at the top here, as well as all of our team members. We look forward to hearing from you, and if we can answer any questions, you know how to get us. And with that, I will turn it over to the next speaker. Thank you.
Hi, everyone. My name is Diane Hall, and I am a senior health scientist at CDC, and I also serve as our rural health lead. Today, I'll be giving you a quick update on where things stand in terms of vaccination, and then I'll talk through some vaccine confidence and demand concepts, and then I'll end with some resources. Next slide, please. This map is from our COVID data tracker, and the darker colors represent more doses administered. And these data are what we receive. So states and entities send the data to CDC. Child vaccinations, as we've heard, is relatively new, and our data teams are working on getting those views added to our data tracker. So check back frequently. This is a great resource, and we are constantly adding updates to it in terms of new pages, and we update the numbers regularly. Next slide, please. In addition to the data that are sent to CDC, we also have a very large survey that yields monthly data. This National Immunization Survey is something that we do regularly with immunizations, but we are doing specific COVID modules. So we have an adult COVID module, and we're starting a child COVID module. So this is a random digit dial survey, and it is weighted. And there are several questions that we ask, and I'll go into that a little bit more, but I'll just be talking about the adult module today. Next slide, please. So these data are also available from our data tracker, and these numbers come directly from that National Immunization Survey. So take a look at the red box. We are able to look at the data by rurality. So we've got essentially urban, suburban, and rural areas. The orangish or salmon colored bar actually represents people who said that they probably or definitely will not get vaccinated against COVID. And as you see in that red box, that bar or that color is larger on the rural bar. And we do update this regularly. So these data are for the month of October. Next slide, please. I'm not going to go through all of this. We've got a lot of speakers today. But essentially what this shows is that vaccine confidence, vaccine equity, and access to the vaccines are all critical in order to achieve high uptake. The trick here is the balance. Let's see, next slide. So this framework comes from WHO, and it is the framework with the behavioral and social drivers of vaccination that we are using. And this also informed questions on the National Immunization Survey. So it's really important to understand that there are a lot of things happening. So not just how people are thinking and feeling about the vaccines, but also what sort of things are happening in the context or in the community. Is it a social norm to get vaccinated or not? How motivated are people to get the vaccine? And then just practical issues. Do people have accurate information? Are they able to get it? That kind of thing. And all of that comes together to lead to uptake of vaccination. Next slide, please. We talk a lot about vaccine confidence, and we use that frame rather than vaccine hesitation. So vaccine confidence actually has a few components to it. So the idea is that people have to trust in the vaccine, trust in the healthcare system, and also trust in the processes that resulted in the vaccine. So the slide that Dr. Mark showed, showing how the process was stacked up instead of stretched out linearly, I think is a really important one. Next slide, please. So we talk about the ladder to building demand, and this involves making sure that the vaccines are easy to get, that people see that vaccination is beneficial, that it's made convenient, that it's desirable to get vaccinated. And eventually we want to get to the point where it's seen as normative, just this is what you do, and then necessary. So this is in order, shifting from sort of like individual level kinds of things to getting more to that community level social norming. Next slide, please. So Shannon mentioned social media, and yes, social media is absolutely critical, but we also know that a lot of times there is misinformation or disinformation circulating on social media. And so we have some toolkits, and there are a lot of links on the slide, and we'll get those into the chat for you. But what you want to do is make sure that you're sharing factual information and debunking false claims or myths that are being spread online. There are a lot of shareable resources that are available from CDC, but also other partners. And you can go to a site like factcheck.org to actually check to see if the information that you're seeing on social media is correct or not. And we do have tips for addressing misinformation. And we have a team that develops a state of vaccine confidence reports. We do those twice a month. And we just released our 18th report, I believe. And each of those revolves around a particular topic. Next slide, please. So I want to talk through some of our resources. There's a lot of information out there, and there are a lot of slides or a lot of pages on our webpage. So probably the easiest thing to do is to go to our main COVID page. Our COVID vaccination page gives information about the vaccine, how to get the vaccine, information after vaccination, but we also have information for specific populations. Next slide, please. This is one of my favorite resources. So we call this our field guide. And what I like about this is it uses that vaccine ladder that I showed a couple of slides ago, but it includes specific information that operationalizes it. So it takes it from conceptual to here's how you might implement this. And we have worked with our partners to gather examples. And so there are examples in this field guide. The strategies are drawn from historical vaccination efforts. So what we know about non-COVID vaccinating. They're supported by positive outcomes from evaluation research. So there is some evidence to them. And we include those real world applications. And what's really exciting is we are also working on a rural considerations addendum to this, and we're hoping that will be out soon. But take a look, there's some really great information in there. Next slide, please. We also worked on a project engaging the arts to build vaccine confidence, and there's some really creative examples out there. There are people in communities doing some really great things, so we like to promote this to communities as another way to get messaging out there about the importance of getting vaccinated. Next slide, please. Okay, these are the State of Vaccine Confidence Insight reports. We create these regularly. We emphasize the major themes that influence vaccine confidence and uptake. We do social listening. We look at web metrics. We use immunization survey data. We look to see what kind of questions are coming into CDC info. And the reports seek to identify those emerging issues of misinformation, disinformation, and places where intervention efforts can positively increase vaccine confidence. So I urge you to check those out. As I said, they come out around twice a month, and we have all of the archive there on the website. Next slide, please. We also have some resources for communities to do their own rapid community assessment. And what this will do is help you get a better handle on low vaccination rates in your community, understand barriers and facilitators, and identify potential strategies. There's some really great tools in here that you can use. You can do this anywhere from 1 to 3 weeks, depending on your resources available. This is also in Spanish, and we are working on a version 2.0 of this, so that should be coming soon. Next slide, please. We know that in a lot of rural communities, a lot of times print resources are absolutely critical. And so we have a web page that pulls all of those together. And there are fact sheets and different types of resources there for you to print out and use. Next slide. You may not be aware of this one. The National Resource Center for Refugees, Immigrants, and Migrants is part of the University of Michigan and one of CDC's grantees. And they've got some really great materials that are translated into dozens of languages, and all of the materials are free and available online. So I urge you to also look at those. Next slide, please. One other resource or support that CDC provides is that we do vaccine confidence consultations. And so far, we've done 42 of those. And this can be phone, but depending on resources, sometimes we have actually also been able to deploy people to a community to assist. And typically, if we deploy somebody, we will use that rapid community assessment that I just talked about a couple of slides ago. But a lot of times, these are just phone consultations, and you pull in whoever you need from your side. We'll get our staff together and we'll talk through what's going on, what you're seeing, some strategies that we know about that other communities are trying. And we've done repeats of these. Sometimes, someone will call back and request another follow-up consultation like a month later or something like that. There are some common themes that we're hearing across these consultations, and those are listed there. We've also done some rural listening sessions, and we're hearing a lot of the same thing that's listed here. A lot of distrust in government, and in some communities, even distrust in the healthcare system. But you can request one of those consultations by emailing confidenceconsults@cdc.gov, and we will get back to you. Next slide. The red on here shows the rapid community assessments, or RCAs, that we've conducted to date, and several of these have been specifically rural. This is also where we're hearing about mistrust in government, rumors and myths, people not being quite sure what to believe, some access issues, some language barriers, and honestly, in some rural communities, there's just COVID-19 fatigue. People just are tired of hearing about it and tired of talking about it. And so rural communities are getting really creative about what they do in terms of outreach and messaging and partnership. Let's see, next slide, please. And that is my last slide. Please feel free to email me with any questions. You can reach me at either of those emails on the slide. And now I'd like to turn things over to Dr. Frances Feltner, who's the director of the Center of Excellence in Rural Health at the University of Kentucky. Dr. Feltner, it's all yours.
Good afternoon, everyone, and thank you for joining us today in celebrating National Rural Health Day. In Kentucky, our governor has made a proclamation for us to celebrate Kentucky Rural Health Day. So welcome, everyone. Next slide, please. The mission of the center is to improve the health and well-being of rural Kentuckians. And over the past 30 years, the center has worked with many partners within our communities, with our providers, our students, and individuals to provide health professional education, health policy research, healthcare services, and community engagement toward reaching that mission. The center also serves as a federally designated Kentucky Office of Rural Health and operates Kentucky Home Place, recognized nationally as a community health worker model. Next slide, please. In response to COVID-19 and the low vaccine rates that we were seeing in rural Kentucky, we reached out and picked a target population of 30 rural Appalachian counties and 2 West Virginia counties. These were selected due to the high poverty levels and poor health outcomes and individuals living in poverty. In Appalachia, we're having a life expectancy on average of 2.4 years less than those living in non-Appalachian states. The geographical area that confines us from transportation is extremely limited. High rates of poverty makes personal transportation a burden. An already unhealthy rural population, COVID-19 certainly threw some problems to our community. The target counties had high social vulnerability index scores with health risk behaviors, high rates of comorbidities, and high rates of SV. It is imperative that individuals in our communities receive the vaccine. Unfortunately, in our Appalachian counties at the time, we had very low vaccine rates. Next slide, please. So our goal of our Appalachian Community Health Days was to vaccinate Appalachian communities by providing community outreach, increase access by removing those barriers, needs assessments of individuals, and provide education and positive messages to increase vaccine confidence. Our community health workers are trusted members from their communities and are able to reach their neighbors and friends. And this was very helpful in reaching our community. Next slide, please. Building upon our Kentucky home place model, we hired additional community health workers to reach the targeted counties. The goal of the community health workers was to work with our community partners to increase access to the vaccine sites. Education on the importance of COVID-19 vaccination and conducting our outreach activities was key to increasing the vaccine rates in our underserved, hard-to-reach population. Coming together in Appalachia, we can solve our issues and increase our COVID vaccine with positive building of confidence in vaccine. Next slide, please. As we looked at scheduling across our 32 counties that we were doing outreach in, we developed a tracking tool. If you click on the first link, it'll take you to our tracking tool for our Appalachian Community Health Days. And here, if you'll scroll up just a little bit on the slide, you'll see a map. And as she puts the mouse on the little circle, it will show the location of where the day is going to be, the time for individuals to come and join us. Many of the community partners would join us on each of these days to bring access to services. Many people during COVID-19 did not get their preventative care, such as blood pressure checks, A1C checks. And so we went back to the old-fashioned community health days where partners come together to also deliver the message of COVID-19 vaccine and to actually bring the vaccine with us to the people. Next slide, please. While she's moving to the next slide there, we wanted to develop a campaign where people would learn, understand, and decide about the vaccine. And I wanted to show you an actual Community Health Day video to let you see firsthand the work that the community health workers and our team is doing in the community. You can start the video, please. While she's coming out of that slide to the video, I do want to give special thanks to Sarah Varney and Mary Carney with NPR as they shared pictures with us for the video, as they wrote an article that came to our community. So here we go.
We are at the Buckhorn Children's Home, and we are having our Community Health Day, where we bring resources with a goal of reaching as many people as we can with the COVID vaccine. We've had people here today of all ages, some who have never had a COVID shot, receiving their first vaccine, and that's our goal today.
When the pandemic first started, I wasn't necessarily anti-vaccine. It wasn't a priority for me. About 2 months ago, I had a close relative. He and his family had been to Florida. All of his family members, with the exception of him, had been vaccinated. When they came home, he and his wife and one of his daughters had actually contracted the coronavirus. And for the wife and daughter who had been vaccinated, it wasn't more than a mild cold. But he actually was admitted to the hospital, later to ICU, and was transferred to UK. He ultimately went on the ventilator and a week later died. And so after that, it entirely changed my outlook on the vaccine. And, what we need to do to fight and to eventually eradicate the virus.
So I was scheduled to get my vaccine the first week it was available to us healthcare workers here at the UK Center. And that was also the same week I found out I was pregnant. So I did hold off for a little bit more data. I spoke with my doctor at UK Healthcare as well and decided to get vaccinated at 19 weeks. Olivia here was the baby that I was pregnant with, and she is 2 months old, and she's doing well. She's meeting all her milestones. Hi. I was hesitant, but it was scarier what would happen to me if I got COVID and what would happen to Olivia. And I also have a toddler at home, Alex, who is 2. So I didn't want to leave them with just a single parent. For me, it's the best thing you can do to protect your unborn babies.
It's really hard for people to have transportation into a clinic and a time of day that they can come or a time that they can get someone to give them a ride and to get the services that they need. And so today we bring the services to them.
He likes the music in church.
We are at the Owsley County Elementary School. We are here doing a drive-through COVID vaccine clinic. We just have some booths set up here today. We are offering the COVID vaccines.
This is my mother, Hester.
This is my daughter.
Ask her where she lives.
With her mommy.
I live with my mom right now. She's 90.
I think events like today are a great opportunity for community partners to come together and educate the public on various health issues. It gives us the opportunity to meet people that we wouldn't normally get to interact with, do some giveaways, door prizes, and just educate the public on various health issues.
The most successful Appalachian Community Health Days that we have had have been led by our faith-based community. Our pastors in rural Appalachia are very important to our communities in relaying messages of importance. When they step up to the plate and say how important it is to get your COVID vaccine, people listen. Pastor Billy Joe Lewis in Leslie County actually helped us set up one of our community health days. He did work ahead of time to let the church know that we were coming and how important it was to get your vaccine. Pastor Lewis had preached a funeral about 2 weeks before we had our community health day at his church. The person died of COVID. And so he was really glad to get us to come bring the vaccine to his population.
We were real hesitant about getting the vaccine at first, but then we ended up catching COVID-19 again. It started with my wife at work. She brought it home. Ran through me and ran through her son. At the time, my wife was pregnant, and you hear all these stories about women having miscarriages due to COVID. So that was a really, real scary part for us too. So we went ahead as soon as we could. We got the vaccine.
The USA Drone Port is working with the University of Kentucky to help promote COVID vaccination.
It's a partnership we started last year in March because of COVID. And we started exploring the concept of how drones can be utilized in specifically pandemic responses.
We're also going to have leaflet drops. Leaflet drops haven't been done since Vietnam. This leaflet drop will hang on the bottom of a drone. You can turn it at any speed you want, but it can drop up to 200 leaflets a minute. We're going to be using biodegradable materials so it doesn't litter everything and stay that way for very long. This is to help people understand that there's free opportunities in their area to come and get COVID shots.
We're very thankful for all the community resources that have come together to help us to have these Appalachian Community Health Days. And that's what we are in Appalachia. We're neighbors and friends, and we can come together and we can bring services to the people in our communities. And with the next slide, that concludes my presentation. Thank you for joining.
Good afternoon, everyone. I believe we're working on getting the next set of slides up, but in the meantime, I just wanted to say thank you to all of my fellow speakers so far, and thank you so much, Dr. Feltner. That was an amazing video. Stories are always so powerful and so compelling to convey messages, to convey empathy, to elicit empathy, so important. So hello, everyone. I think we're working on getting the slides back up, but my name is Darcy Graves and I work in the CMS Office of Minority Health. And I also have the pleasure of serving as the co-chair of the CMS Rural Health Council. I will now provide information on various CMS COVID-19 vaccine resources and other HHS agency resources. So as we move on to the next slide, we will continue to highlight National Rural Health Day. As we continue to highlight National Rural Health Day, we want to take a moment to further emphasize our commitment to improving the quality of healthcare that rural Americans receive and reducing the disparities that impact their ability to access care by sharing the rural-focused resources listed on this slide that may be of use to you and your community. We'll get into a few of these resources in a little bit more detail in the next few slides. On the next slide, you'll see one resource in particular that I want to mention, and that is our Rural Crosswalk, CMS Flexibilities to Fight COVID-19. This resource highlights the numerous COVID-19 related provisions that CMS has issued by regulation or waiver since the start of the pandemic that impact various rural providers, including rural health clinics, federally qualified health centers, critical access hospitals, rural acute care, PPS hospitals, and skilled nursing facilities. Next slide. During November, our office is also recognizing National Diabetes Awareness Month. Diabetes is shown to disproportionately impact rural communities. Those living with diabetes are also at an increased risk of serious illness if they were to contract COVID-19, adding to the importance of vaccinating in rural America. Our Health Observance webpage has been updated to highlight multiple diabetes resources for providers and patients, and they are also listed on this slide. To highlight a few listed here, the Diabetes Disparities in Medicare Fee-for-Service Beneficiaries Data Highlight examines disparities in quality of diabetes care and preventable utilization of healthcare services by race, ethnicity, and social determinants of health factors for Medicare fee-for-service beneficiaries with type 1 or type 2 diabetes. The Managing Diabetes Medicare Coverage and Resources is designed to help patients with managing their diabetes and health coverage. This resource is also available in Spanish. And lastly, our Diabetes Management Directory of Provider Resources is a directory designed to facilitate diabetes treatment for primary care teams, particularly providers working with Medicare beneficiaries and underserved populations who experience a higher prevalence of type 2 diabetes and its complications. On the next slide, we'll highlight two CMS OMH web pages that include COVID-19 resources. These web pages feature lists of resources for healthcare professionals, consumers, and patients, individuals with limited English proficiency, as well as non-English speakers, partners who are educating COVID-19 vaccine recipients, long-term care facilities, and health plans and programs. On this slide, we'll see two COVID-19 resources that we released under our From Coverage to Care, or C2C initiative, that talk about the COVID-19 pandemic and highlight key information from the Department of Health and Human Services, as well as our sister agencies, the CDC and at home at CMS. The first one I'll mention is coronavirus in your health coverage, Get the Basics. This piece discusses how to protect yourself and your family during COVID-19 with tips for staying healthy. It also has information about what health services are typically covered under Medicare and Marketplace plans. The second one, called Stay Safe, Getting the Care You Need at Home, offers tips for how to stay healthy during COVID-19 with information about scheduling health appointments from home and planning ahead for prescriptions. We also talk a little bit about telehealth. Both resources, which are also available in 7 other languages, can be found on our website at go.cms.gov/C2C COVID-19, and all of that goes together. Next slide. Given the increased use of telehealth during the pandemic, we also have resources that compile key information on telehealth. We released 2 CDC telehealth toolkits, one aimed at patients and another at providers. With our patient-facing toolkit called Telehealth, What to Know for Your Family, patients can learn about the types of care that they can receive through telehealth, how to prepare for an appointment, what to expect during a visit, and more. This resource is also available in Spanish. With our provider-facing toolkit called Telehealth for Providers, What You Need to Know, providers can learn how and when to use telehealth. Topics include how to set up a telehealth services, how to conduct a successful visit, and how to keep up to date on telehealth payment with information for Medicare and Medicaid. Both resources can be found on our website at go.cms.gov/C2C telehealth. And again, that's all one word. Next slide. The HHS We Can Do This campaign is a national initiative to increase public confidence in COVID-19 vaccines while reinforcing basic prevention measures such as mask wearing and social distancing. The campaign offers various toolkits, including a general audience toolkit that is regularly updated for anyone that wants to help increase public confidence in the COVID-19 vaccines. They also have toolkits specific to rural communities and essential workers in agriculture, and include resources for how to build vaccine confidence and promote preventive measures with these communities. You can also find these and other tailored toolkits at wecandothis.hhs.gov. Next slide. Federal resources have also been developed for American Indian and Alaska Native populations. In addition to the toolkits noted on the last slide, the We Can Do This campaign offers an American Indian and Alaska Native Tribal Leaders Toolkit, which includes resources for tribal leaders who want to help increase confidence in COVID-19 vaccines within their communities. There are also fact sheets and social media posts for Northeast, Northwest, the Plains, Southwest, and all regions, which answers 4 questions to help build vaccine confidence with the American Indian and Alaska Native communities. We also wanted to take this moment to highlight resources from the Indian Health Services and CDC if you are looking for additional information for this group. Next slide. If you or others are looking for vaccine location, visit vaccines.gov to find a location and make an appointment. Next slide. I encourage you all to explore CDC's Vaccinate with Confidence web pages. Here you'll find tips on how to encourage confidence. Resources are also available for community partners, including tip sheets, guides, checklists, conversation starters, and more. There's a lot of information there, so I encourage you to spend some time going through the site to look for resources specific to your needs and your community. There is even a map of data tracking vaccine hesitancy at the county level. Next slide. Now that we've covered all of those resources, we want to take this opportunity to remind you all that you must take care of your own, must take your own action to protect yourself, your family, and your community as we continue to navigate this public health emergency. We must use every tool available to stop this pandemic. It is still important to wear a mask, watch your distance, and wash your hands. Next slide. If those within your community are still hesitant about getting the COVID-19 vaccine, here are 6 key points that you can share with them. First and foremost, as we've heard today, the COVID-19 vaccines are safe and effective. And although some may have side effects, these are normal occurrences. It is important to remember that it typically takes 2 weeks after your last vaccine for the body to develop full immunity against the virus. That means if you received the Pfizer or Moderna vaccines, you are not fully vaccinated until 2 weeks after the second dose. Or if you received the Johnson & Johnson vaccine, you are not fully vaccinated until 2 weeks after the 1-dose vaccine. Vaccines are now more widely available, and everyone 5 years and older is now eligible for a COVID-19 vaccine. If you're fully vaccinated, you can go back to doing some of the things that stopped because of the pandemic, like feeling more comfortable dining indoors or going to catch a movie at the movie theater. If you are talking with someone who is fully vaccinated and unaware about the boosters that are now available, let them know that if they received the Pfizer or Moderna vaccine, they are eligible for a booster 6 months after the completion of the initial series. And if they received the Johnson & Johnson vaccine, they can go get their booster 2 months after they received that first dose. Next slide. Cost should not be a barrier to anyone, but understanding that is important. Regardless of your insurance, or even if you are uninsured or undocumented, there is no cost to get the COVID-19 vaccine. You may be asked for your insurance card if you have one, so the insurance can be billed appropriately, but no one should incur a cost when getting the vaccine. For Medicare beneficiaries, this means that no beneficiary should pay a copay deductible for a COVID-19 vaccine. We want to be clear. You should take your red, white, and blue Medicare card with you so your insurance can be billed, just like with other services, but there is no cost to you. For people who are undocumented, they are also able to get the vaccine at no cost. A person does not have to show ID, although they may be asked. If a person provides their ID or information, it cannot be used for other purposes. Next slide. Here are additional links if you are looking for more information about the no-cost aspect of vaccines. Next slide. We want to make sure our Medicare beneficiaries are on alert for scammers trying to steal their Medicare number. To reiterate, Medicare costs that covers the vaccine at no cost. So if anyone asks for your Medicare number to try to get early access to the vaccine, that is a scam. Here are a few important things to highlight to your patients or your community. You can't pay to put your name on a list to get the vaccine. You can't pay to get early access to the vaccine. And do not share your personal or financial information if someone calls, texts, or emails you promising access to the vaccine for a fee. Next slide. If someone you know did pay a fee or get a bill for a COVID-19 vaccine, you should have them first check the receipts and statements they got from their provider for any mistakes. Call the provider's office to ask about any charges that may be incorrect. The person you speak with may be able to clarify the charges or realize that they made a billing error. Review the Medicare summary notice for errors and report anything suspicious to Medicare by calling 1-800-MEDICARE. If they have other coverage like a Medicare Advantage plan, review the explanation of benefits and again, report anything suspicious. After taking these steps, if they think they were incorrectly charged for the COVID-19 vaccine, ask for a refund. And if a provider is charging for an office visit or other fee, but the only service received was a COVID-19 vaccine, report them to the HHS Office of the Inspector General by calling 1-800-HHS-TIPS, TIPS, or visiting tips.hhs.gov. Next slide. I know Shannon and Dr. Hall mentioned this a little bit. We're going to talk a little bit more about vaccine hesitancy and how we turn that into confidence. We thought it would be helpful if we explained a little bit about the difference between vaccine hesitancy and vaccine confidence. Vaccine hesitancy is the delay in acceptance or refusal of vaccines despite their availability. It's generally based on beliefs about risks, personal choice, and mistrust, which can vary based on age, geography, race, and a number of other factors. Some common reasons that individuals are still hesitant to receive the vaccine include thinking COVID-19 is not a serious disease, while some believe getting vaccinated is a personal choice rather than a public health responsibility. Others are taking the wait and see approach, and some just don't trust the healthcare system. Next slide. Vaccine confidence is the trust that parents, patients, or providers have in recommended vaccines, the providers who administer vaccines, and in the processes and policies that lead to vaccine development, licensure, manufacturing, and recommendations for use. Confidence in the vaccines, the vaccinator, and the system all support people's decision to get vaccinated. The strong confidence in the vaccines within communities leads to more people getting vaccinated, which leads to fewer COVID-19 illnesses, hospitalizations, and deaths. Next slide, please. And while there is a difference among various populations and why they may be hesitant to get a COVID-19 vaccine, there are some common strategies for overcoming vaccine hesitancy. As Shannon mentioned, trusted messengers are so important. One-on-one conversations with a trusted healthcare provider are the most effective way to overcome vaccine hesitancy. Other messengers include local public health departments and government agencies like the CDC and FDA. Encourage peer-to-peer messaging. Receiving vaccine information from other trusted or influential sources can also help people overcome vaccine hesitancy. Consider targeting specific populations through media and social media campaigns, and be sure to offer resources translated into languages spoken in your community so that the information is widely available. Remove functional barriers wherever possible. Letting people know when, how, and where they can get their vaccine may make it easier to convince them to do so. Also, reinforcing the message that no one should have to pay to receive a COVID-19 vaccine, even if you don't have health insurance, may overcome concerns about its costs and may also help people avoid potential COVID-19 vaccine scams. Finally, provide and promote accurate information and messaging. Accurate information is available to people who seek it on the CMS, CDC, and FDA websites. Next slide. We'll wrap up with a few final messages that you can use to provide with anyone who still may be hesitant about the vaccine, even if you've taken all of the previously mentioned steps and shared relevant resources. Scientists who have been working on the technology used in the new COVID-19 vaccines for over 20 years. More than 100,000 people from diverse backgrounds took part in the vaccine trials. The vast majority of doctors who have been offered the vaccine have taken it, and there is no cost to get the vaccine. We hope that this information we provided you with today, along with all the messages on how to build confidence, will encourage those in your community who are not yet vaccinated to get vaccinated. Next slide. For our last slide, we wanted to share how you can get in contact with us. You can use the emails here included on the slide to reach out regarding any questions. You can also sign up for one of our listservs to receive the latest information on COVID-19 policies, programs, and resources. I will now turn it back over to our partners at Ketchum to facilitate the Q&A portion of this webinar. Thank you so much.
Thank you to all of the presenters. We will now begin the question and answer portion of this webinar. As a reminder, you can submit your questions via the questions chat box. We will address as many questions as time allows, and we will now get started. And so the first question that we actually wanted to ask was one that's actually for Dr. Hall. And so the question that we have was, when resources specific to faith communities have been, would be updated or will be available?
Thanks for that question. I did add some links into the chat for some recent things. The We Can Do This site that Darcy mentioned also has a really nice toolkit. CDC does have some pages specifically for faith leaders that look like they've been archived. And so I am going to find out what's going on with those pages and if we will be planning to update those.
Thank you, Dr. Hall. The next question that we had was actually for Dr. Feltner. And so the question that we have was, how did you connect with faith leaders in Kentucky or in other states? Did you have a staff member personally reach out to faith leaders, or did you already have an email list to send requests to all faith leaders in the state?
Thank you for the question. That is a good one. Our community health workers are actually located in those counties, and they know the resources, they know the faith-based leaders, they work with them on a continual basis. So it was very easy for us to connect with them.
Okay, thank you, Dr. Feltner. Our next question that we had was actually for Dr. Marks. We actually did receive a couple of questions for you, and one of the ones we wanted to start off with was related to children. And so what was the significant acuity difference between the control and intervention groups for children ages 5 to 11 during those trials?
I'm not sure exactly what I'm not sure I understand the question exactly. The children were from a range of basically a range of children, including about 20% of whom had various comorbidities, none of whom was severely immunocompromised, but there were a variety of children with other medical conditions that were enrolled. That might be what somebody was asking. That was about 20% of those randomized to the 5 to 11-year-olds.
Okay, thank you for clarifying that. And then another question that we had, which can be answered by, excuse me, I'm sorry. Then another question that we had was, if a person cannot make the scheduled time to receive the second dose of the vaccine, what is the grace period? The maximum amount of time that will be allowed to get the second dose so that it doesn't disrupt the effectiveness of the vaccine?
Yeah, that's a really good question. Ideally, in the clinical trials, it was a 7-day window. But I would say that if somebody is past that 7-day window, it's a really good idea. Don't decide you shouldn't get it. Someone shouldn't get it. I think that's something to be thought through with the individual provider, because it may be that if it's 10 days, 2 weeks, it's still fine to just go ahead and get that second dose. It really depends on exactly how long that time has been.
Okay, thank you, Dr. Marks. And then we have another question here. This one is related to rural health. Well, clearly, this one is also related to the rural experts. And just the question would be, how many centers of excellence in rural health are there throughout the U.S. and where are they located?
I actually tried to answer that question myself. It is a good question. And the issue is that when I did the research, and Shannon, you may be able to do a little more than that, but each state has its Office of Rural Health located in rural Kentucky. Ours is definitely in rural Kentucky, and we're glad about that. But as far as centers like we have, there is not another center that hosts academic programs, as well as our outreach program, our research and policy group, and we have a federally qualified healthcare center. We have a residency program within our center. So ours is a little unique in that it has other things there. I know Georgia was working on a center of rural health, so I'm not really sure. When we did our research, and Shannon, help me if you can, could we find another center like us? There are other centers. So Shannon, I'll leave it to you now.
So just as she said, there is a Office of Rural Health in every single state. There are separate, while there is not another rural excellence like we're aware of, apparently we have found the best after that video. I hope y'all all enjoyed that. There are your primary care associations, there are rural health associations. There's a lot of information out there. More than glad if you're looking for one in particular in a state, feel free to reach out to me. I will connect you, whether that's your Office of Rural Health or maybe one of the primary care associations. But Dr. Feltner has the name down perfect there for the great work that they're doing there.
Thank you both for answering that question. We had one comment from the chat, and we just wanted to open this up for a dialogue from the panelists and just get your thoughts on it. The comment read, please remember that everyone does not know how to use technology or have the equipment. So what resources have been useful for those not using computers and technology? With the digital divide, what's been the best way to reach them?
I'll be glad to jump in real quick. So for telehealth, I think we have to remember that we have to meet the patient where they are, right? So whether that's a phone call, we all know that even having those phone calls at this point, for our rural health clinics and FQHCs, those phone calls still fall under the public health emergency so that we can still get reimbursed for those phone call. The other thing is that if you're a rural health clinic and you receive the COVID testing and mitigation funds, there is a line in there that's an allowable expense for digital technologies. Again, I'd be glad to talk on an individual basis, but there are some opportunities for you to expand the telehealth that you're currently doing in your clinic, and to make sure even digital literacy programs to really help folks. We have a great program here in South Carolina through a company called Palmetto Care Connections, who actually teaches seniors how to use this kind of stuff. I know if you hand me, I'm a Samsung girl, if you hand me an iPhone, I can't really navigate that, sorry. But there are some things out there, but I'll stop there for other speakers.
Okay, I'd like to add to that too, Shannon. And really and truly, one of the issues and barriers that we found in rural is people could not go online and make appointments. They did not know how to use the tele connections and the things like that they would need to go online. They didn't have computers, didn't have access to broadband, any of that. So basically, our community health workers reached out in their communities to identify the people and get the messages to the people. So sometimes it's still one-on-one in some of these communities. Some of the communities that we bring the outreach days to, you cannot use your phone or the internet there. It is so rural. So sometimes it's one-on-one reaching out to people is what we have to do in rural still.
Did any of the other panelists have anything that they'd like to add? Okay, so then we did have another insight, and we just read this out loud and leave it open to any of the speakers who would like to give their thoughts, as well as others in the chat who can join as well. And so the insight would be that there's a very high degree of hostility towards government CDC in South Carolina and the South. And so the refusal to get vaccinated is considered a badge of importance to this substantial minority, and the subgroup is resistance to outreach and persuasion. The methods that were suggested during the webinar were good suggestions for those on the fence groups, but maybe not for those that are strongly resistant to get vaccinated. And so the question here would be, how do you influence those who are part of those groups?
This is Diane. I can't believe. Let me take a pass at that one. I think that's part of the reason that we have that vaccine confidence ladder. As more and more people become vaccinated and people are aware that more and more people are becoming vaccinated, our hope is that it becomes the social norm. It almost becomes the default that you get your vaccine. I know that flu vaccines don't have the uptake that we like to see, but they have become pretty normative. Your provider asks you, have you gotten your flu vaccine when you go for your physical? So our thinking is that, that's the hope. But the truth is there are some people that just will not get the vaccine, and we are aware of that. I did put a bunch of links from our partners in the chat, because there was also a question in there about sort of how divisive it's become and how politicized it's become. And the Beaumont Foundation has done some really nice work, and they have a link with some communication tips. And then National Rural Health Association has some really great information, and I put a link there. And there's another one that is Trust for America's Health, CDC Foundation, and Beaumont. So there are good resources out there, but the reality is some people just aren't going to get vaccinated.
All right, thank you. Did anyone else have anything that they'd like to add? Okay, well, that concludes the Q&A portion of the webinar. And as a reminder, the slides from today's presentation will be posted on the CMS OMH website in the coming days. We wanted to thank you all for joining and participating, and we wanted to let you all know to have a great day. Thank you.